Hi friends, in today's class we will discuss about neovascular glaucoma, its etiology, pathophysiology, the stages of the development of glaucoma, the prophylaxis for treatment and the treatment part. So coming to what is neovascular glaucoma, it is a secondary glaucoma which occurs secondary to neovascularization of angle. Coming to the etiology, so in etiology, the most common causes are proliferative, diabetic retinopathy. So it is the most frequent cause of neovascular glaucoma, and then we have retinal vascular occlusive disorders, that is CRVO is the second most common cause. So almost 45% of ischemic CRVO, neovascular glaucoma is formed, and it is the highest during first 7 to 8 months. So that's why it is also called 100-day glaucoma in these cases, right? So this is CRVO. Then we have other causes like carotid artery obstructive disease, this is third most common cause of neovascular glaucoma. So in this, there is neovascularization of iris, angle and the glaucoma. So here, the decreased perfusion of ciliary body reduces the production, which results in normotensive or hypotensive eyes despite of extensive synovial closure. So occlusion or stenosis in the carotid siphon or ophthalmic artery can be found. This can be demonstrated by cerebral angiography or magnetic resonance angiography. Okay, so other causes include chronic uveitis, tumors, Coats disease, frosted branch angiitis, Churg-Strauss syndrome, etc. So we need to remember especially these three etiologies and others are secondary. So coming to the pathophysiology part. Why does this happen? So there is the first important thing, that is retinal ischemia. So all these things which we have discussed about, they all cause retinal ischemia. So this leads to release of the VEGF from the Muller cells. This VEGF are apt upon endothelial cells and form fragile new vessels. So these new vessels, they can, uh, you know, form neovascularization of the angle near the pupillary border, and it blocks the trabecular meshwork. So these fragile new vessels, these are first seen at the pupillary border. So this is one of the most commonly asked questions in MCQs, and later it extends into the iris surface, then the angle. So in the angle, what happens is that there is a fibrovascular membrane which is formed. So this here in the angle there is formation of fibrovascular membrane. This membrane then contracts, leading to synechial angle closure. So they can be thus an open angle glaucoma which occurs in this stage, that is the neovascularization of angle stage. So here we have open angle glaucoma. Then after the formation of the membrane and its contraction, when there is synechial angle closure, it will lead to angle closure glaucoma. So we have both types of glaucoma in this. So we will just, the stages also are the same. So first is the pre-rubeosis stage. Stage 1 is pre-rubeosis stage. So in this stage, there are no signs of neovascularization, only the predisposing ocular or extraocular condition is present. So here we have to perform a fluorescent iris angiography to detect this stage. Then in the stage 2 is pre-glaucoma stage. So this is the rubeosis iridis. In which the neovascularization has set in. Okay, so there are fine vessels which can be first seen at the peripupillary area, then we can see through gonium these vessels. Okay, so the IOP is normal over here. Okay, then we have open angle glaucoma stage. So as we discussed here, in this stage, the IOP begins to rise and stays elevated. So it may rise suddenly, or it may rise slowly depending upon the type. So they can also be hyphema in these cases because these vessels are very fragile, right? Then we have angle closure glaucoma stage. So most of these cases are presented at this stage. So because of contraction of the membrane in the angle, it leads to synechial closure, atrophy and UVA, and flat appearance of the iris. Okay. There can be other signs of angle closure glaucoma like conjunctival congestion, corneal edema, and later it will lead to glaucomatous optic atrophy. that is stage 5. So in stage 4, most of them are detected. On gonio we can see dense synechiae. Okay, so this was regarding pathology and the stages. Now coming to the management part. So we have to first identify the cause and treat it. So we have to give prophylactic treatment. So in case of predisposing factors, we have to manage those predisposing factors. So like in case of PDR, we can perform a pan-retinal photocoagulation with or without anti-VEGFs. And in case of ischemic CRV also PRP can be done. And we have to perform FFA. So if it shows ischemia only, we have to perform this. Okay, then we have to perform in cases of ocular ischemic syndrome. The patient need to undergo carotid and arteriectomy if there is more than 70% stenosis. And in some cases, there can be improvement with the help of superficial temporal and middle cerebral artery bypass surgery. That is superficial temporal artery, middle cerebral artery bypass. And there is a procedure called gonio photocoagulation. So this is a laser therapy which treats the neovascularization of the angle before the development of neovascular glaucoma. Okay, now coming to the medical management of this. So as usual, we have to reduce the IOP with the help of topical beta blocker, alpha-agonic and carbonic anhydrase inhibitors, hyperosmotics, prostaglandin analogs, but miotics are contraindicated. So we should not give because they can increase the inflammation. Then along with that, we have to do anti-inflammatory drugs like steroids and cycloablation. Then anti-angiogenic drugs like intravitreal or intracameral bevacizumab. So that is commonly 1.25 mg per 0.05 ml is given. Right, so they can be bevacizumab temporary regression and also sometimes permanent regression. So coming to the surgical management. Surgical management, we have trabeculectomy, tube shunts and cycloablation depending upon when the patient presents. So trab, tube shunts and cycloablation. So trab along with mitomycin C can be used. And also it should be noted that for better surgical outcome, sufficient PRP and anti-VEGF should be given, and after that this surgery should be performed. Okay. So within 1 week of injection of this anti-VEGFs, we have to perform trab. Tube shunts or the glaucoma drainage devices, we have Molteno implant, Ahmad glaucoma valve, and Brevelt implants. So these are also used. So it is the use of anti-VEGF agents is recommended at least 24 hours prior to the surgery. So here uh, 24 hours prior we have to give anti-VEGF. So here within 1 week we are giving for trab for these tube shunts within 24 hours we should plan. And also the tube here must be placed in a scleral tunnel to minimize the chances of erosions. And cycloablations are the cyclodestructive procedure for refractive cases in which they have painful eye. So this was regarding the management of the glaucoma and all. So thank you for watching. We'll see you in the next class. Please do subscribe to my channel for such informational videos.